especially how are we going to recognize the stroke and what should we do if we have recognized the stroke, and what is the pathophysiology behind what we are going to do. So in 1970s, the WHO defined stroke as a neurological deficit of cerebrovascular cause that persists beyond 24 hours or is interrupted by death within 24 hours. So this was 1970s definition. And according to this, in the United States, stroke is a leading cause of disability and is ranked as fourth leading cause of death. And in 2011, stroke was the second most frequent cause of death worldwide, accounting for 6.2 million deaths out of total. Okay, the stroke can occur at any age in childhood. The incidence of from 30 years of age onwards. Etiology varies by age. Advanced age is one of the most significant stroke risk factors. Men are 25% more likely to suffer stroke than women, and 60% of deaths. These are the statistics. Okay, so what is a stroke? Acute neurological deficit that is caused by disruption of blood supply to any part of the brain, and this causes stroke. Okay, there are two types of a stroke: an ischemic stroke, and stroke is caused by blockage of the blood vessels, and hemorrhagic stroke is caused by rupture of blood vessels. We are going to discuss the hemorrhagic stroke tomorrow, and today we are going to discuss about it. What you are seeing in this diagram is this a blood vessel line the brain, and is blocked where the line indicates, and once it is blocked, the whole of the area that is supplied is affected. Due to this, the brain is going to be affected. What kind of thrombosis and what kind of blockage may occur? There are four reasons for this blockage: thrombosis, an embolismic hypoperfusion, thrombosis. Okay, so what is this? Clear thrombosis is the obstruction of a blood vessel by a blood clot forming locally. An embolic clot that is formed somewhere in the body and has traveled all the way into the brain artery. It is causing its blockage, and that blockage is resulting times, since the blood vessels of the brain are and arteries, there is systemic hypoperfusion. The blood pressure falls and the end arteries do not receive the blood, and the junctional area of the two arteries gets affected, and that is the junctional zone infarct and just the junctional zone ischemia. And then there is venous thrombosis. Venous thrombosis may also cause ischemic stroke. Okay. The classification of ischemic stroke is according to the area, according to the arterial supply that is affected. And this is the total anterior circulation infarct. Anterior circulation means an internal carotid artery that breaks between an MCA and ICA, and it supplies the anterior part of the brain. And the posterior circulation is the PCAs, the two PCAs behind, supplying the brainstem and the cerebellum. So the total anterior circulation infarct, the partial anterior circulation infarct, the partial circulation infarct is that not the carotid is blocked, but only ACA or MCA is blocked. Right. So if the carotid is blocked, is a total anterior circulation stroke, which is causing blockage of the middle cerebral artery and the anterior cerebral artery. And if either only one of the middle cerebral artery or the anterior cerebral artery is involved, it's called partial anterior circulation stroke. Then there is posterior circulation stroke, in which the posterior cerebral arteries are involved. Then another type of a stroke occurs, which is not confined to the arterial territory, and it is a very small pinhead type infarct, and this is called lacunar infarct. So the total anterior circulation stroke, the partial anterior circulation stroke, and okay. So a stroke is an alarming situation, and what is this alarm tells you? This alarm is you have to approach the stroke victim fast. What does this fast means? Fast is an abbreviation that tells you how would you recognize the stroke, and the F stand for face. Any abnormality that is occurring acutely on the face in the face should be considered as stroke unless proved otherwise. A is for arm or any limb. It must be any limb, an arm or a leg that gets weak suddenly and acutely. It is also it may also be a cause of a stroke. And S is stand for speech. So face, arm, speech. Any combination of it, any one of it, or all of it, if are affected acutely, some acutely, just in the wink of an eye, then you should think that perhaps a stroke is occurring. And what does T stands for? T stands for time. Time is that you do not have enough time to waste. And this stroke should be treated as early as possible. So it's very important to recognize the stroke and then to take the patient to the neurological care institute. The approach should be fast because time is brain, and with stroke, the lost is the time is lost, the brain is lost. As you lose the time, you are going to lose the brain. As center, there is a center where the maximum destruction happens. There's a maximum destruction happens in this, and if as we move away from it, the destruction is the magnitude of destruction is less and less. Okay, so this is what happens in a stroke. When an arterial territory is involved, the central portion of the arterial supply is damaged. Whereas the cells in the central area are damaged, and what you're seeing in this blue spot, what you're seeing, and the area surrounding this damaged area, the cells in this damaged area or this red area are unconscious. The dead tissue cannot be revived, but this unconscious tissue can be revived. And this red penumbra. Umbra, blue area which is lost and which cannot be recovered, and penumbra is covered. Okay. But if you are in the side number of this, all the penumbra is lost, and then you see all the penumbra is lost. You could have saved this penumbra if you had acted fast, right? So once you have recognized this stroke, what you're supposed to do is recognition of the stroke is also, as this type of damage may occur anywhere from this hierarchy from cord. If it is a suprapontine or if it is a cortical area involvement, then there must be a hemiparesis. There must be a hemiparesis, and of the face which is involved to be on the side of the hemiparesis. And this is always a lower half of the brain, ipsilateral to the side of the weakness, and this means the stroke is cortical or suprapontine stroke. It is again a suprapontine stroke, and if it is a pontine stroke, the hemiparesis will be there as it was in the suprapontine, but the involvement of face would be on the opposite side, and this involvement should involve the upper and lower face both. All right. If the involvement of face is on the other side of the hemiparesis, contralateral to the hemiparesis, then it is a pontine stroke. And if it is on the same side of the hemiparesis, it is a suprapontine stroke. But if the face is not involved at all, but only the cranial nerves are involved, the bulbar nuclei are involved, this is an infrapontine stroke. Okay, so if you have recognized this stroke, the any of the combination may occur acutely. Now, what are you going to do with this stroke? The management of a stroke deals all around to save this penumbra. The dead tissue is in the central tissue, and the surrounding tissue is the penumbra. This penumbra needs to be saved. Okay. So what are we going to do first of all to identify if it is really stroke or not? So neuroimaging is the image is the investigation of choice in gold standard to diagnose the stroke. The goal of imaging in a patient with acute stroke is to exclude hemorrhage. Okay. Differentiate between irreversibly affected brain tissue and reversibly impaired tissue. Reversibly ineffective tissue and effectively impaired tissue. Okay. Identify the stenosis or occlusion of the major or extra and extracranial arteries. So what is the goal of neuroimaging? Number one, exclude hemorrhage, because the treatment of ischemic stroke is going to devastate the hemorrhagic stroke. So you have to identify if it is a hemorrhagic stroke or it is a ischemic stroke, right? So first of all, you should exclude hemorrhage. Then differentiate between irreversibly affected brain tissue and reversibly impaired tissue. You have to identify the penumbra and umbra, and then you have to identify stenosis or occlusion of the major extra and intracranial arteries. Any artery which is blocked, where it is blocked, and that has to be identified on this neuroimaging technique. In this way, we can select patients who are candidates for thrombolytic therapy. So what is this thrombolytic therapy? Thrombolytic therapy is what kind of neuroimaging are we going to do in acute stroke? For diagnosing ischemic stroke in the emergency setting, CT scan has a sensitivity of 16% and a specificity of 95%, 96%, whereas MRI has a specificity of 98% and sensitivity of 83%. For diagnosing hemorrhagic stroke in emergency settings, CT scan is sensitive about 89% and specific about 100%. Whereas MRI has sensitivity of 81% and specificity of 100%. So both can be used to diagnose an early stroke according to this data, but CT scan is easily affordable, number one. Number two, less cost effective, and number three, it can be done very quickly instead of having um, instead of having we were talking about the ischemic the CT scan and MRI. So either can be done, but CT scan has an advantage of less cost effective. Number one, number two, it can be done quickly. CT scan is the advantage of being available 24 hours a day and is the gold standard for hemorrhage. And on CT, 60% of infarcts are seen within 3 to 6 hours, and virtually all are seen within 24 hours. What are we going to do? What are we going to see? Obscuration of the lentiform nucleus, also called as blurred basal ganglia, is an important function which is seen acutely in acute stroke. It is seen in middle cerebral artery infarction and is one of the earliest and the most frequent signs seen. This is a hypoattenuating brain tissue. If you recognize, if you can appreciate, the sulci on the right, are prominent, while on the left, where the arrow indicate, are not so prominent, and there is a grayish tinge of area involving whole of the area. This is the early sign of ischemic stroke in a CT scan, right? So insular ribbon sign. Insular ribbon sign refers to the hypodensity and swelling of the insular cortex. You see, this is the insular cortex. If the other side would have been shown, you could easily differentiate that the other insula is quite prominent, while this insula is quite blurred. So this is an insular ribbon sign. So what you have seen: hypoattenuating brain tissue, insular ribbon sign, and the dense MCA sign. This is very important. When MCA is thrombosed, it appears like this, where the arrow is result of thrombus or embolus in MCA. On CT angiography, occlusion of the MCA is visible like this. On CT angio, a 3D imaging of the blood vessels can be obtained, and you see if you compare the other side, if you compare the two sides where the arrow is indicating, the artery is blocked, the artery is ending, and you cannot see further, right? Another technique is CT perfusion. With CT and MR diffusion, we can get a good impression of the area that is infarcted, but we cannot preclude a large ischemic penumbra. Perfusion will tell us which area is at risk. The limitation of CT perfusion is the limited coverage. Studies were performed to compare CT with MRI to see how much time it took to perform all the CT studies that were necessary to come to a diagnosis. And it was demonstrated that plain CT, CTP and CTA can provide comprehensive diagnostic information in less than 15 minutes, provided that you have a good team. In case of MRI, diffusion weighted image, you see this diffusion weighted image, very acute. It's quite specific for acute ischemic strokes to identify, and it can identify within about 2 hours. Within about 2 hours. You see, this is a peninsular ischemia, and you see this is an anterior cerebral artery infarct, bilateral anterior cerebral artery infarct, and it's quite prominent in diffusion weighted image. MCA infarct, you see it is clearly visible on CT, that is irreversible change. There is a match of diffusion and perfusion, so no therapies need to be given. What you see is here is the diffusion-perfusion mismatch. Diffusion-perfusion mismatch, it is also a technique white is it white areas so white
Hello, sir. Hello.
Hello.
सर अनम्यूट कीजिएगा अपने आप को.
अनम्यूट कर दिया. अब आ रही है आवाज?
यस सर, आवाज आ रही है सर. कुछ नेट का
अब
मसला
आ
है
रही है
आई
आवाज?
थिंक. जी
ओके
सर, आ रही है.
okay. So quickly हम करने की कोशिश करते हैं. So this
Okay,
is a
sir.
diffusion. You see this is the diffusion image in which a very small area is seen in the center, and when you see the perfusion image, this small area is surrounded by a gray area which is extending anteriorly and posteriorly, and this is diffusion perfusion mismatch. This in the perfusion scan, the central white area is the dead tissue, and surrounding grayish area is the penumbra that can be saved. So this is diffusion perfusion mismatch. that gives you the clue that you can try to save this penumbra. Okay, so what is the drug? What are the procedures that can be done? It is a thrombolysis reverse tissue plasminogen activator, which can be given in the artery or in the vein to dissolve this clot which has occurred. So the RTPA is given within 3 hours of the onset. So it is very important to determine when the patient will see normal last. Once this is determined, and if you are in the therapeutic window, you complete RTPA. The very contraindications in diagnosis of ischemic stroke symptoms not suggestive of suburban hemorrhage, all symptoms less than 3 hours, stroke injection. Okay, so this is the indication of RTPA, and once it is given, whom should not receive RTPA if there is if there is a duration of more than 4.5 hours of onset of a stroke, patient is more than 80 years of age, taking oral anticoagulants, and patients with NIHS score more than 25, and patient with a history of stroke and diabetes in the past. So this thrombolysis therapy can be given intra-arterially, and risk and benefits of thrombolysis with intravenous patient have been associated with early worsening, and half of these outcome altered as a result. With intra-arterial thrombolysis, about 10% of patients have major early hemorrhage, but again, many of these occur in already infarcted fields and do not clearly alter final of thrombolytics includes systemic hemorrhage, angioedema, and allergic reactions. All right. Another very important and very important aspect of acute stroke management is mechectomy. You see, a catheter is passed in the artery, just like we are doing the angiography, reaches this clot, and there it tries to retract this clot, and this is mechanical thrombectomy. Significant complication in this mechanical thrombectomy occurs about 7%. Okay, then there is a final role you have. Once you have stroke, now there is time for neuro rehab. Stroke rehab is perhaps helps patients to return to normal life as much as possible by regaining and rhythms of everyday living. It also aims to help them survive and to adopt difficulties, prevent secondary complications, and educate family members to play a supporting role. A rehabilitation team is usually multidisciplinary, working together. These include physicians trained in rehab medicine, nursing staff, physiotherapist, speech therapist, or social workers. So all of them play a role in the rehabilitation of this patient treat stroke. and this is how we should treat stroke. So